speaker, Hamza Al-Quraan, is a clinical nurse specialist with more than 15 years of professional nursing experience. He currently serves as a clinical nurse specialist at Ministry of National Guard, Health Affairs in Riyadh. Please let me welcome Mr. Hamza.
Thank you, Mariam, for the welcoming, and I would like to express my deepest appreciation for the organization committee and the scientific committee for giving me this opportunity to present our experience about outpatient transplant for lymphoma patients. So through this session, I will walk you through simply background about the lymphoma and outpatient transplant program, program outcome and statistic, lessons learned, and future direction and conclusion. So lymphoma is a type of cancer that begins in the lymphatic system, especially in white blood cells called lymphocyte. Lymphoma is the most common blood cancer, accounting for approximately 4% for all newly diagnosed cancer cases and 3.3% of cancer-related death globally in 2024. International statistic, approximately more than 800,000 new cases of lymphoma are expected globally in 2023. Lymphoma causes approximately more than 300,000 deaths globally each year. In US, lymphoma is the seventh lead cause of cancer death, and the age standardized mortality rate of all lymphoma is 4.7 per 100,000 people. The global prevalence of lymphoma is approximately 7.6 million. And in the US, there were an estimate more than 800,000 people living with lymphoma in 2023. 5 years relative survival rate for all lymphoma is approximate 73.1 in US, and 5-year survival rate for Hodgkin lymphoma about 87.3. 5 years survival rate for non-Hodgkin lymphoma is 74.1. In Saudi Arabia, as you see in the slides, the second in males, the second most frequent cancer is non-Hodgkin lymphoma, and for both sexes, male and female, fourth rank for the cancer in the Saudi Arabia. Despite there's a lot of treatment modality nowadays for treatment lymphoma, but still in one stage, in one lines of treatment for Hodgkin and non-Hodgkin lymphoma, the standard of the treatment or the standard of the care for some cases is still transplant. So our program background. In National Guard, King Abdulaziz Medical City at Riyadh provides comprehensive evidence-based care for adult patients require stem cell transplantation and cellular therapies. The program performs both autologous and allogeneic stem cell transplantation and other cellular type therapies. Since of the official establishment of the transplant program in March 2010, the division has performed more than 1,000 stem cell transplants, representing a significant institution milestone. The success has been supported by a multidisciplinary team that included transplant physician coordinators, pharmacists, nurses, and allied health professionals dedicated to delivering high-quality patient-centered care. The outpatient program, autologous stem cell outpatient program, started in 2010, and the outpatient transplant model launched in 2018. Temporarily paused during a COVID pandemic and returned back at the end of the 2022, then resumed after the pandemic. Primary population for our program, lymphoma patient receiving beam conditioning. So why outpatient transplant? Globally, we show improve inpatient experience and satisfaction, home environment, reduce inpatient bed utilization, lower healthcare costs, promote early mobility and family support. Outpatient transplant workflow pathway. Again, as mentioned in all the previous presentation, a multidisciplinary approach, a multidisciplinary team is milestone for every work or every success. So multidisciplinary team task force initiated to develop policies and clinical practice guidelines, consist inclusion and exclusion criteria for outpatient transplant, patient clearance for outpatient transplant, outpatient transplant and admission flow process, the rapid access bed inpatient unit, pathway after working hour and triage system for the rapid access beds. Discharge from outpatient setting, the daycare. We'll go through the guidelines. We're starting inclusion criteria. By the way, this inclusion criteria not all for the lymphoma, for the whole program. It's covered for auto and allogenic. Under age 60 of the years, good performance status with echo 0 or 1, live within an hour drive from the hospital or willing to stay at housing close to the hospital, have a responsible designated caregiver who can be with the patient 20 hours a day, 7 days a week. Exclusion, fully myeloablative conditioning for the allotransplant, thiotibia, busulfan, cyclophosphamide-based conditioning for auto, for CNS lymphoma excluded, Hablo, transplant, cord blood allogenic, history of liver, kidney, or heart disease, non-compliant patient. Patient assessment for outpatient transplant, we have two checklists major before to select the patient or the started the patient for our program. Checklist number 1, eligibility assessment, which is the inclusion criteria. The second checklist is compliance and social assessment. So one of the part or one of we did from the policy and guidelines is modifying the conditioning regimen. You know, the beam conditioning is the most conditioning protocol, chemotherapy protocol using for auto-transplant for the lymphoma patient. And this protocol is consists for chemotherapy, starting from day 7, day 6 to until day 0. So the etoposide and RC, including the protocol, is most of the institution using by 2 or divided by for 12 hours. So in outpatient setting, we should modify this protocol to be suitable as outpatient setting. Again, the daily assessment for the disciplinary through the patient journey with daily nursing assessment, nurse coordinated flow up, health educator involvement, and pharmacy support, daily communication across the team. So as the picture showed, the highly effective and integrated communication between healthcare providers is very important, and it reflects our outcome. Our program is starting from a pre-transplant nurse coordinator, which is responsible for the patient clearance, for a pre-transplant workup and clearance. Inclusion and exclusion criteria should be raised in that assessment, and the checklist 1, checklist 2, as we mentioned, should be done before the patient to start the journey of the outpatient. All of the clearance and inclusion should be co-signed and should be provided, and assessment with the most physician responsibility. Again, before the patient to start the outpatient auto-transplant journey should be assessed, and special session for the education should be provided for all the patient by health educator, provided education material about the outpatient transplant, about the central line, about the chemotherapy protocol, and provide special card, which is called alert card, including the on-call, including all the contact number. The patient, if he need any queries, he can contact 24 hours. And provided the special roadmap for an Arabic roadmap for the patient. Again, in our program, we have dedicated outpatient transplant coordinator, and she's responsible to review pre-transplant checklist and clearance form. This is a second checkpoint for the patient after already checked by first coordinator as a pre-coordinator transplant. Daily visit to outpatient oncology until full recovery or admitted. Check conditioning was ordered 24 hours prior, and check the roadmap to check the availability of the roadmap, to check all the clearance form and the other investigation. Daily assessment by SCT nurse coordinator and assigned SCT physician and consultant covering the outpatient service. Collected the lab order administering the conditioning. Make sure the patient received order medication. Will be helped with the consultant and multidisciplinary team and the nurse team leader. As a type of continuity of the care pathway after working hour, as we mentioned before, we have on-call, physician on-call, and transplant coordinator on-call. Patient need medical attention after working hour. The patient will be directed to the rapid access bed in the inpatient unit or the emergency department, depend on the urgency of the condition complaint. The patient will call the on-call physician and the phone if she develop any symptoms. The SCT coordinator on-call phone will be a backup, a second contact number. The on-call physician will apply the triage system for the patient's symptoms. The on-call physician will guide the patient to either come to emergency department or come to the rapid access bed in patient unit, or wait until the next day to come to the clinic for assessment based on the triage system. If the patient is directed to come for direct admission, then the charge nurse for the inpatient unit receive the patient and active the patient as inpatient. The charge nurse will on call for assessment, and he will be on call the consultant for the assessment again. So, again, as a continuum of the care, the dedicated outpatient transplant coordinator should be daily endorsement by email the sheet, including the all active patient. She will send by email for involved teams, transplant day status, current clinical issues, recommendation for the on-call team, improve continuity and patient safety. And including each email, provide a triage system. It will guide the on-call physician to classify the patient depend on their symptoms and query questions. 24 hours, 7 days on-call contact number for the patient. Patient report symptoms to transplant team, clinical triage performed by on-call physician, direct admission pathway available when needed, dedicated standby ER bed in patient unit, and rapid escalation for urgent complication. Program outcome statistic. We did, since we launched the outpatient autologous transplant for lymphoma, total 19 patients. Started in 2018, two cases, then in 2019, 4 cases, and paused during the COVID pandemic and resumed with high number in 2024 at 6 cases. The type of the patient, we did 15 cases with diagnosis Hodgkin lymphoma and 4 cases with non-Hodgkin lymphoma. Some characteristic of the patient: hematopoietic stem cell specific comorbidity index. You saw 9 patients with 0, which is one of the eligibility for the candidate patient for outpatient transplant. 4 cases with comorbidity index 1, 2 cases with number score 2, 4 patient, and score 3, 2 cases. And as you mentioned, by experience, we can now feasible for to start the patient with comorbidity high, and we build our experience how we deal with these patients. From the total cases, 14 of the 5 patients completed their treatment as outpatient without need any admission, and 14 is hybrid, which is mean in their journey they need admission to complete their courses. Duration of treatment, 14 patient, with average for the outpatient duration, the average days was 14, and for the inpatient duration, the average day is 19. And to complete the average duration for all the courses, it was 19. Reason for admission, 4 cases was admission due for reason for was bare protocol. When we start our program, you know, bare conditioning, it has complicated like GI toxicity and cytopenia, which is myeloablative conditioning. And like a global recommendation, after day 4 or 5, we'll admit the patient before to develop any complication. But when we start our program, we was admitted the patient. So 4 cases was admitted just as per protocol. 3 cases was admitted due to febrile neutropenia, and 3 cases with upper GI toxicity. 2 cases was lower GI toxicity, 1 cases for facial cellulitis, and 1 cases for non-compliance, and no caregiver. In our journey, we saved a total of 255 business days was saved for outpatient transplant from the admission. Evidences from the literature, lower severe GI toxicity and infection reported, comparable engraftment outcome, improved patient satisfaction and quality of life, support careful patient selected model, challenging and lessons learned, need strong caregiver commitment, fast, effective communication is initial, a clear admission criteria prevent delays, education must be repeated and documented, nursing coordination is central to success. A future direction, expanded outpatient eligibility is safely increased fully outpatient completed rate, formal patient satisfaction survey and cost analysis study, published institution experience. Conclusion, we conclude outpatient transplant, autologous transplant is feasible in selecting the former patient, strong nursing coordination drive success, improve patient-centered care, optimize hospital resources. Our experience supported continued to expansion. So this is our team from the adult stem cell transplant behind any success. And again, happy Nurses Weeks. We thank you all for this attending.
Thank you, Hamza. Any questions? So we can finish a successful nursing 13 nursing conference, SSBMT. Thank you so much for the people who stay until the last minute. Appreciate it, really. Thanks a lot. Appreciate all of you, and have a nice end of week. Thank you.